Hello, everyone. Good morning and good evening, all my participants in the ICC. Thank you for your coming into this chatting room as well. I'm P.Y. Cho, the coordinator and the organizer of the ICC. ICC so far has been almost 2 years since the pandemics. So we are always delivering the lectures about the Cleft or orthognathic surgery or any the congenital dental facial or craniofacial deformity to all our participants. Today, we are so honored and very lucky to have Professor Bony Padwa here be with us. Professor Bony Padwa now received her DMD from Harvard School of Dental Medicine and her MD from Harvard Medical School. After finishing her oral and maxillofacial surgery training at the Massachusetts General Hospital, she completed a craniofacial surgery fellowship at the Boston Children's Hospital. Professor Padwa is the professor positions of the oral and the maxillofacial surgery at the Harvard School of Dental Medicine as well. She is the Leonard Cabot DMD MD chair of the oral and the maxillofacial surgery and the oral surgeon in chief at the Boston Children's Hospital. And Professor Padwa has a special interest in treating patients with cleft and craniofacial deformities, and her clinical research is centered around this patient population. She has authored more than 180 scientific articles and book chapters, and has lectured both nationally and internationally. So, by the way, I have introduced two of the panelists today to give us the comment for this lecture. One is the very well-known Professor Gung Choi. Today, Professor Choi is very busy for his national academic conferences, so he is the president. So for now, Professor Choi is as the position at the Department of PRS at the Asan Medical Center in Seoul and Korea. We have another panelist, teacher, Professor Sato, Nobuhiro Sato. Yeah, currently, Professor Sato is the associate professor and the medical director at the Department of PRS at the Showa University Hospital in Japan. So can't wait to have Professor Padwa to give in the very special lecture. The topic is the Cleft orthognathic surgery. So please, Professor Padwa, thank you.
Struggle with after having practiced for several decades in a high-volume cleft center. This is a picture of a patient born with a bilateral complete cleft lip and palate between the ages of 4 and 15. And you can see when she's in the deciduous and mixed dentition, she has a relatively convex facial profile, but during the skeletal growth spurt, she develops maxillary hypoplasia and ends up with a concave facial profile, which is not uncommon. And in fact, several studies in the 1990s reported that the rate of Lefort 1 osteotomy in patients with cleft lip and palate was approximately 25%. We did a study many years ago at our center where we looked at the rate by cleft type and found that patients with cleft lip and palate required a Lefort 1 osteotomy almost 50% of the time. If we included, like these other studies did, patients with isolated cleft lip and isolated cleft palate, our rate of Lefort 1 in all cleft patients was 20%, so similar to what had been reported. But patients with cleft lip and palate have a much higher rate of maxillary hypoplasia. The orthognathic surgery is a wonderful surgical procedure to improve facial aesthetics. And in cleft patients, It allows the proper skeletal framework for eventual nasolabial revision. But as in non-cleft orthognathic surgery, the results for cleft orthognathic surgery are really only as good as the treatment plan. And what I'd like to do is spend a bit of time today talking about what I've learned and what I continue to struggle with regards to the treatment plan. And then I'll spend some time also talking about some of the things I've learned and struggle with in terms of technique. The treatment planning session prior to initiation of any treatment should involve the surgeon, orthodontist, and definitely the prosthodontist, even if there's just a plan for canine substitution. This interdisciplinary care helps avoid mistakes and misunderstandings, and the goal is to treat to the best facial aesthetics and obtain a functional occlusion. It's important to determine the skeletal deformity, and in cleft patients, the primary skeletal deformity is going to be maxillary hypoplasia, often in 3 dimensions. These patients frequently also have inadequate bone grafts, residual fistula, dental gaps, missing lateral incisors. They can have a combination of maxillary hypoplasia as well as mandibular prognathism or asymmetry. Occasionally, they even have bimaxillary hypoplasia. It's important to look to see if they have a cleft lip, lower lip deformity and a chin deformity, and also to make note of their nasolabial deformity, although this likely not to be treated at the time of Lefort 1, at the time of orthognathic surgery. Lefort 1 osteotomies definitely changed the appearance of the nose. As I noted, the hypoplasia in these patients is primarily in the maxilla, typically in the sagittal plane, often in the vertical plane. And given that the transverse dimension is the most unstable orthodontic and orthognathic procedure, it's not uncommon for these patients to have residual transverse deficiency. And the hypoplasia, the maxilla, is not just at the level of the dentition, it extends to the infraorbital rims. These patients often have relative mandibular prognathism because of this sagittal and vertical maxillary hypoplasia, which gives them this overclosed prognathic appearance. They can have residual dental gaps and oral nasal fistula, as well as a missing lateral incisor. It's also important to assess not only their mandible, also their chin and their lower lip. They frequently have, especially in patients with bilateral clefts, this hypertrophied, superiorly displaced, and anteriorly rotated lower lip. And this is due to difficulty with bilabial closure. And so the lower lip is everted and it's thick. And because of that difficulty with bilabial closure, they can get this variable degree of vertical elongation and posterior displacement of the chin and flattening of the anterior mandible, which we call the cleft lip, lower lip deformity. And as I noted also, they can have residual nasolabial deformities and nasal and septal deviation. The caudal margin, such as in this patient here, can be managed at the time of Lefort 1. More formal revision of the lip and nose should take place after the skeletal framework has been corrected with orthognathic surgery. Now, when we assess patients for Lefort 1 osteotomy, we judge the vertical maxillary position based on two-show at rest and smiling. And patients with clefts have a variety of residual labial deformity, which can make assessing two-show at rest somewhat difficult, including the vertical notch of the upper lip, deficiency in the median tubercle, in patients with bilateral cleft lip, deficiency of the prolabium and lateral festooning, and some patients can have a long or short upper lip. And the question is whether these residual labial deformities can be managed after a Lefort 1 osteotomy or whether they should be managed before the Lefort 1. This is an example of a patient on the left of the screen preoperatively when we're assessing her vertical maxillary position, and then postoperatively on the right side of the screen. So preoperatively, you can see there's asymmetry in her two-show at rest. So you have to make a decision about which side you're going to treatment plan to. Will you treatment plan to the cleft side, which is short, or to the non-cleft side, which is shows just 2 to 3 millimeters versus the 4 to 5 millimeters. So in this particular patient, we decided to treatment plan to the non-cleft side, knowing that after the Lefort 1, there would be a revision to the lip to get rid of this notching and make the two-show more symmetric. Similarly, this is a patient who has a deficiency in the median tubercle on the non-cleft side, and it's a little hard to see here, but she has more incisor show on the non-cleft right side than she does on the cleft left side. So in her, we know postoperatively we'll be able to augment the deficient tubercle with a dermal graft, and so we treatment plan actually off of the cleft side. She has 2 to 3 millimeters of two-show on the cleft side and 4 or so on the non-cleft side. But after the Lefort 1 and dermal graft, you can see that there's symmetry in her two-show. A little more difficulty is this young boy with a bilateral complete cleft lip and palate. He has a deficiency in the prolabium with lateral festooning. It may be difficult to see, but when I see him on clinical exam, you can see more of the mesial surface of the central incisors, very little of the lateral surface of the incisors, and the sweet spot is actually right above the orthodontic bracket, right at the orthodontic bracket in the midpoint, just after the deficiency in the tubercle. So the plan is for a Lefort 1 osteotomy, using that as the vertical position. And then after the Lefort 1, he'll have a dermal graft to the median tubercle and trimming of the festooning to give a more symmetric and even two-show at rest. The long upper lip can be difficult to manage. This boy, a patient of John Mulliken's, has quite a long lip, no two-show at rest. After Lefort 1, I was able to get a few millimeters of two-show, but when you have to be very careful, if this patient has a normal lower third facial height, you don't want to lengthen the maxilla to get two-show because you might increase the vertical height of the anterior face, making things unaesthetic. So in these patients, you have to be careful. If someone has normal facial third or even a long facial third, but don't show any two-show at rest with a long upper lip, you might actually have to trim vermilion to get two-show. The hardest one really to deal with is a patient with a short upper lip. This is a patient with a short upper lip repaired at another institution. He actually has vertical maxillary excess in addition to a short upper lip. And probably the best thing to have done would be to revise the lip. That would tell us exactly where the maxilla could go. But that's for a variety of reasons. I went ahead with a Lefort 1 osteotomy. And this is him after vertical maxillary impaction, and then he'll have a labial revision to increase the size of the length of the short upper lip. So assessing that two-show at rest can be tricky in patients with clefts, and that their residual labial deformity really need to be assessed and managed as part of the workup. Now, occasionally we see patients who have an acceptable occlusion, but they have unacceptable facial aesthetics. In these patients, if the mandible is in good position, you have to then try and create a negative overjet so that you, either with dental decompensation, orthodontically, and or differential extraction to create a negative overjet to allow for a Lefort 1 osteotomy. If they have bimaxillary hypoplasia, they certainly would benefit from bimaxillary advancement. So this is a young boy, again, a patient of John Mulliken's with a bilateral complete cleft lip and palate. He had very minor maxillary hypoplasia, certainly in the range of dental camouflage. He and we were unhappy with his facial aesthetics, so our orthodontist was able to create some negative overjet to allow for a few millimeter, 5 millimeter or so maxillary advancement. He has a really nice postoperative occlusion with bilateral canine substitution with adequate overjet and overbite, and you can see the improvement in the profile with that minor amount of maxillary advancement. This is a young man with a bilateral complete cleft lip and palate, again, a patient of John Mulliken's who has bimaxillary hypoplasia. He actually has an excellent preoperative occlusion, class 1 molar and canine with a missing lateral incisor, but he was unhappy with his aesthetics. So he had bimaxillary advancement of 8 millimeters and a 6 millimeter advancement genioplasty, same premorbid occlusion, and he's had a dental implant, but that's the change in the profile with bimaxillary hypoplasia. So although patients with clefts can have a good occlusions or occlusions that are amenable to orthodontic treatment or orthodontic camouflage, again, treating to the best facial aesthetics is the most important thing to do. Now, what about patients who have significant maxillary hypoplasia? And by that, I mean an anterior crossbite of more than 10 millimeters that's primarily secondary to maxillary sagittal hypoplasia, not in addition to mandibular prognathism. In these patients, in my practice, there are 3 options. One option is a standard Lefort 1 osteotomy with a bone graft if necessary, and that graft is on the anterior wall of the maxilla, not posteriorly at the pterygoid plates. And I do this in patients who have a reasonable size maxilla that may have just a missing lateral incisor or bilateral canine substitution. Patients who have a really tiny, diminutive maxilla with many missing teeth, these are patients I would treat with the technique of distraction osteogenesis. The technique that I like least for patients with significant maxillary hypoplasia is bimaxillary surgery, where you're treating the maxillary sagittal discrepancy, not only with a maxillary advancement, but also with a mandibular setback. And the problem with this is that you're setting the chin back, but then you need to do an advancement genioplasty. And I don't think treating maxillary hypoplasia with bimaxillary surgery gives the best aesthetics. So just an example of each. This is a young man, patient of John Mulligan's again, born with a left unilateral complete cleft lip and palate, who has developed fairly significant maxillary hypoplasia. He's been treated with clear aligner therapy or Invisalign therapy. We're doing this more commonly now. And he had his virtual surgical plan is here. The plan is for a 14 millimeter maxillary advancement with 3 millimeters anterior disimpaction with a bone graft here along the anterior wall. And here he is 3 months postoperatively. He's still quite swollen. You can see this is not a patient in whom I'd like to set the mandible back. And once the swelling resolves, he will have a nice profile. Oftentimes, I don't treat the cleft lip, lower lip deformity at the time of the Lefort 1 because John Mulligan often likes to do this at the time of labial revision. This is a young man with a right unilateral complete cleft lip and palate, was repaired at another institution. He has significant maxillary hypoplasia, in the 18 to 20 millimeter range, as well as this very tiny maxilla with multiple missing teeth. And in this patient, I use the technique of distraction osteogenesis because there's just not a lot of maxilla to hold on to when doing the advancement. Here he is after the distraction appliance is removed. You can see a year later or so, he has a nice orthognathic profile. I personally like his mandible. I think he has a nice, strong mandibular position. Obviously, it would have been better without the facial hair. I think you would have seen the chin point rests nicely on a line from Nasion. And here's his postoperative occlusion. He's gone on to have further bony and soft tissue grafting here and has had his dental implants placed, but not the teeth, so I wasn't able to show you what his restored dentition looks like. But here he is before and after, and again, his primary problem is maxillary hypoplasia, and he was treated with a Lefort 1 osteotomy. This is a patient with a bilateral cleft that was repaired at another institution. He has significant maxillary hypoplasia. He actually has mandibular hypoplasia with a really sizable anterior crossbite. And for a variety of reasons, I treated him with bimaxillary surgery. You'll see I'm not really happy with the result. This was a Lefort 1 osteotomy of 10 millimeters and 3 millimeters of anterior disimpaction with a sagittal split 6 millimeter setback. And then because his chin was on the small side to begin with, I had to do a 6 millimeter advancement genioplasty. He had a reasonably good bone graft high up, but down by the level of the teeth, it was a little vertically short, and also the labiopalatal dimension had resorbed over time because of lack of functional loading from these teeth, so I did an onlay graft at the same time. And here he is about a year afterwards, after bimaxillary advancement and the onlay graft here. He's got good tooth show at rest. He's had the provisional prosthesis placed after implants were placed to the anterior dentition. He's had some loss of the transverse dimension, which, as I mentioned, it's the least stable thing we do orthodontically and surgically. He's gone back into clear aligner therapy. So here he is before and after. Again, restoration of the vertical position. I just was really unhappy with the sagittal, the profile. I think he would have benefited from a little more lip support, and because I had to do a large genioplasty, he already has the cleft lip lowered lip deformity. It further pronounced further the deep labiomental fold and gave him quite a prominent chin button. So again, bimaxillary surgery for correction of a problem that's primarily secondary to maxillary hypoplasia, I don't think gives the best facial, doesn't give the best postoperative aesthetics. Now, what do I do with regards to residual bony defects and or large dental grafts? Well, personally, in my practice, in my hands, I always prefer stage treatment, but certainly I have done and will and do segmental osteotomies. I use stage treatment of doing a bone graft first, followed by orthodontic treatment and surgery, primarily for patients, mostly for patients who require extensive orthodontic therapy in preparation for orthognathic surgery. In these patients, if the teeth on either side of the cleft defect require movement and there's no bone to move the teeth into, and they already have some compromised periodontal health, you can further make the situation not as worse by moving those teeth into that defect. So if they require a fair amount of orthodontic preparation, I like to do stage treatment. I reserve segmental osteotomies for patients who've had a failed or multiple failed grafts. I see a lot of these patients. If there's compromised bone on the cleft adjacent teeth, because I don't think that a bone graft will be even successful in my hands, when there's a large dental gap and it's going to require replacement of multiple teeth, and or there's a soft tissue or bony deficiency that will compromise the implant aesthetics. So this is an example. This is a patient treated at another institution, missed the opportunity for bone grafting and orthognathic surgery. She's in her early 30s. She's got a fair bit of crowding. She's got an omega-shaped dental arch. She's going to require a significant amount of orthodontic treatment in preparation for orthognathic surgery. So rather than do her as a segmental operation, I did her as a staged procedure. She had a surgically assisted maxillary expansion, followed by alveolar bone grafting, orthodontic treatment so that the canine could be brought into the lateral incisor position without doing that surgically. And here she is a year after surgical correction. She has a stable occlusion and improved profile. Now, I do use segmental osteotomies, as I mentioned, for patients who have large dental gaps. This patient had a residual fistula. This is actually a deciduous lateral incisor, the deciduous canine. This is the permanent canine. So she has about 2.5 teeth between the central incisor, a 2.5 tooth gap between the central incisor and the permanent canine with the residual fistula. So she had a Lefort 1 in 2 pieces of advancement of the minor segment to a class 1 canine, leaving space for a lateral incisor. I then placed an implant, which was restored, and you can see it's given her a really nice occlusion and aesthetics. This patient had a bilateral complete cleft lip and palate that was repaired in China. She has orthodontic appliances in place, space for 2 lateral incisors. Problem is she's had 2 failed bone grafts. And I don't think I'll get a good bone graft because the central incisors have periodontal bone loss. And so rather than doing her procedure as a stage technique with grafting followed by single piece Lefort, I treated her as a 3-piece Lefort 1 osteotomy and then also did a shortening advancement genioplasty. So I closed the dental gaps, closed the fistula, And here she is 6 months later. She's just had a labial revision by one of my colleagues. And here is her postoperative occlusion. Apparently her orthodontic appliances were removed about 2 weeks ago, so I'm sorry I don't have pictures. But you can see restoration. She has a good occlusion, and we've gotten rid of those large gaps and the fistula. Now, as I mentioned earlier, these patients, you should always look at that cleft lip, lower lip deformity and see if they have a chin deformity, and that can be treated at the same time with a shortening advancement genioplasty and mucosal resection of the lower lip to provide improvement in the contour of the chin and the lower lip. And as I mentioned earlier, the maxillary hypoplasia isn't just at the dentition, it extends to the infraorbital rims. To improve the projection, you can either do high osteotomies, which I've never been particularly happy with. Patients often complain about the bony prominence. And so I typically use malar implants that I place at the time of the Le Fort 1 osteotomy above the osteotomy secured with 2 screws. This is a patient of John Mulliken's. Before and after orthognathic Le Fort 1 osteotomy and malar implants, obviously better support to the upper lip, that extends all the way to the malar region after the implants. When assessing the CT scan preoperatively, if there are any bony defects, those can be managed at the time of the Le Fort 1. It's something like this. I usually use autogenous bone from the local area, crush it up, and use it. This is the 1-year postoperative CT scan. Patients now ready for dental implants. If they've had a reasonable graft, but because of lack of functional loading and a missing tooth, and they have resorption and a decrease in the labiopalatal dimension, it's a nice time to do an onlay graft. Usually from, I either take that from the septal crest of the maxilla, or if necessary, from around a wisdom tooth and the ramus, and place that at the same time as Le Fort 1. What I struggle most with is dealing with these patients who have a discrepancy between the dental and skeletal malocclusions. So in general, as the surgeon, it's paramount for us to communicate with our orthodontist about how much movement, maxillary advancement, is necessary to provide the best facial aesthetics. And then our orthodontic colleagues should try and tailor that preparatory orthodontics to provide that ideal surgical movement. But sometimes there are patients that have a dental malocclusion that's significantly greater than the skeletal malocclusion. And this is usually the result of multiple missing teeth. And these are the patients I struggle most with. So this is a patient with a bilateral complete cleft lip and palate repaired elsewhere. She has a midline defect with panhypopituitarism, and she has many, many missing teeth. And so, the orthodontists did their best to prepare her for orthognathic surgery. We did her virtual surgical planning. The best I could do in that plan, because she had this 13 millimeter sagittal discrepancy, which from the aesthetic standpoint, she didn't look like she had 13 millimeters of discrepancy. Her chin point is in a good place. I did not believe that she would tolerate that kind of maxillary advancement, which would then have necessitated a Le Fort 1 with mandibular setback and then a genioplasty to bring the chin forward. And so I was really unhappy with this plan. And luckily I have a very crafty orthodontist that I work with. So this picture here on the upper left is an intraoral scan of her maxillary arch. And you can see she has many, many missing teeth. She's missing all 4 central incisors, 2 premolars on the right side, 1 premolar on the left side, which has resulted in this significant collapse of the maxillary arch. On the upper right of the screen, you can see as a result of that collapse in her arch, she has this 13, 14 millimeter anterior crossbite. If, on the other hand, you expanded the maxillary arch to create space for 2 central incisors, so somewhere in this 12 to 14 millimeter range, 6 millimeter central incisors, maybe 6.5 millimeter central incisors, then the anterior crossbite is only in the 6 to 8 millimeter or 4 to 6 millimeter range, which would make single jaw osteotomy with maxillary advancement the surgical plan. And so we decided, rather than proceeding with that bimaxillary surgical plan, to take a step back. Again, as I said, my orthodontist is very crafty. He works with this mesh mixer program. He simulates the orthodontic and surgical movements. Then he has a custom appliance fabricated. I did buccal corticotomies, and I did a corticotomy along the lateral nasal wall. I did not extend the corticotomies posteriorly. I did not take the pterygoid plates off. And then the patient's doing their expansion at home, turning the device. This is after 10 millimeters of expansion. And so once this is complete and we have reestablished the proper dental arch rather than this collapsed dental arch, we'll proceed with a Le Fort 1 grafting and then an ultimate implant placement. Now, just to finish, some of the surgical techniques that I've learned over the years with regards to the dissection, osteotomies, mobilization, and Le Fort 1, post-Le Fort 1 velopharyngeal insufficiency. So in terms of the dissection, there are a couple of key factors here. First of all, the piriform rim on the cleft side in a patient with a unilateral may not be symmetric with the non-cleft side. So in doing your mucosal incision, you have to be very careful because you can cut right through the nasal lining. So when I'm with the residents, I always make sure that they stop and that we do the dissection on the non-cleft side and kind of tunnel through, making sure we can feel bone underneath before completing the incision across the nasal floor on the cleft side. The other thing is that especially in a patient with a unilateral cleft lip and palate, the septal crest and the nasal septum can be quite deviated, making that dissection difficult to do. And finally, the nasal mucosa, if there's a residual fistula, or even if the bone graft doesn't extend posteriorly enough, there can be attachment of the nasal mucosa to the palatal mucosa, and that has to be separated. I like to do that bluntly if at all possible, but it should be done prior to the down fracture, as far back as you can get it. The other thing to mention is in terms of the osteotomies, they're not that different than standard, a patient with a non-cleft. The only difference can be occasionally in a patient who's had an osteotomy of the hamulus at the time of cleft palate repair for mobilization of the flaps, can make feeling the hamulus and feeling the osteotomy of the pterygoid plates a little bit difficult. The other thing is in terms of mobilization, if you have a patient that has a defect like this, once you put row disimpaction forceps on or any way of mobilizing the maxilla, you may find your maxilla in multiple pieces. So in patients like this, I would place the surgical splint, wire the surgical splint on in advance so that if in fact you get fracture through that thin buccal plate, you won't have a multi-segment Le Fort 1 you're trying to mobilize. Most people mobilize Le Fort by pulling it forward, the Le Fort segment by pulling it forward either with pterygoid lifts or with row disimpaction forceps or a combination of both. To improve stability and the long-term postoperative results, the maxilla must be mobilized to the extent that is easily placed in the surgical splint or the custom plate without difficulty. If you're pulling on the maxilla, trying to get it into the splint or into the plate, you certainly are going to have relapse. You really should be able to do this with finger pressure. And to do that, it takes time intraoperatively to mobilize and some tricks. So I'm just going to share with you the trick that works best for me. I do not pull the maxilla forward. I actually push it forward. So what I do is I usually use a Smith spreader or sometimes a laminar spreader. Once the maxilla has been down fractured and mobilized, I put that Smith spreader in between the posterior maxillary wall and the pterygoid plate. And then I open up the spreader, which then pushes the maxilla forward. You can see the muscles stretching, the scar stretching, and the greater palatine vessels stretching. You have to watch the vessels carefully because, especially if they're not terribly robust, they can avulse. So if it looks like they're about to avulse, you either have to dissect them free from the bone on either side, or you should ligate ligate and clip and ligate them. But in my practice, I've found using this Smith spreader or a laminar spreader in this area really allows for the kind of mobilization and advancement that I need to get. Now, we all know that there's a risk of developing postoperative post-Lefort 1 velopharyngeal insufficiency, multiple studies looking at causes. Certainly, our study and that by Phillips has shown that really the best predictor of post-op VP function is pre-op VP function. So if my patients all get a baseline study by a speech therapist and have a nasopharyngoscopy, if they have adequate VP closure, as this patient does, preoperatively, the likelihood, no matter how much advancement, they'll have good VP function postoperatively. Patient like this who has a short palate with no closure for speech sounds on that preoperative assessment, I'm certainly not going to make that better with a Lefort 1 osteotomy. The patients that we just don't really know how they'll respond are those that have borderline VP function. You can't predict whether that VP function will stay the same or will worsen after a Lefort 1 osteotomy. But what I can say is that I've been surprised on many occasions where patients in the immediate postoperative period have fairly significant hypernasality that actually improves. You have to give them 3 to 6 months for them to improve. It doesn't improve all the time, but occasionally it will. And I think it's probably related to the swelling in the soft palate, or maybe even stretching of some of the muscles, particularly when I use that Smith spreader in the back. So usually I don't have my patients, even if they have fairly significant hypernasality postoperatively, I don't have them assessed by our speech team until 3 to 6 months postoperatively, and certainly no surgical correction of their VPI until at least that time. So in the final analysis, what have I learned in several decades practicing in a high volume center? For me, the thing that I've learned the most is how to treat and plan these patients. As I said at the beginning, your results are only as good as your treatment plan. You really need to assess these patients for all their residual stigmata and consider them in your plan. Orthognathic surgery is not just for correcting their occlusion. Even if they don't have a malocclusion, it is helpful for aesthetics, and it does set the framework for final nasolabial revision. If a patient has primary maxillary hypoplasia and would require a large advancement, in general, I prefer advancing it either as a single stage or with the technique of distraction osteogenesis. I believe that bimaxillary surgery and a genioplasty doesn't give the best aesthetic result. I usually reserve segmental osteotomies for patients who have failed grafts, large dental gaps, who have periodontally compromised teeth adjacent to the cleft site, or a deficient soft tissue and bony defects that are going to compromise implant aesthetics. And for those patients that I continue to struggle with, where the dental malocclusion is significantly greater than the skeletal malocclusion, usually as a result of multiple missing teeth and arch collapse, I think maybe the best thing to do is to try and treat that arch collapse first, restoration of a better arch form, rather than compromising aesthetics by significant bony surgery to make up for that underlying dental discrepancy. In terms of surgical technique, you have to spend time during the dissection, particularly the nasal dissection. And mobilization is key. If the maxilla isn't easily placed into the surgical splint or the custom plate, you will have relapse. I use that Smith spreader or laminar spreader between the posterior maxillary wall and the pterygoid plate. And if a patient develops post-Lefort velopharyngeal insufficiency with hypernasal speech, wait at least 3 months to see if it doesn't improve before considering surgical intervention. Thank you.
Yeah, thank you, Professor Padwa. Yeah, thank you for sharing several very challenging cases here with us, and your experience to treat those difficult cases, the patient with the probably unilateral and bilateral cleft lip and palate. At first, we would like to asking Professor Choi, yes, about Choi, Professor Choi, according to your experience, what is your opinion about to treat those patients with the cleft? Do you have the same concept or strategy as the Professor Padwa? So what is your opinion, Professor Choi? Thank you.
Thank you, Dr. Chu. And thank you for the sharing your experience, the Padwa. So actually, about 10 years ago, I actually had the very intense discussion with my senior professor about your paper when we started the premaxillar setback. So can we do or not? So your paper turned out to be very helpful. And then actually, because this issue is not the major topic for today. So actually, overall, I could agree with all the general, the concept. And actually, you presented the maxillary hyperplasia in cleft patients deficient in the not only the vertical but also the sagittal and transverse. Yeah. So I saw that you mentioned that 3 millimeters disimpaction of the maxilla. It means that the orbital ANS part, the downward positioning. Is it right?
Yeah. We usually, when we say 3 millimeters of disimpaction, it's at the tooth level, but obviously ANS would come down as well.
Yeah, so I think the ANS disimpaction, actually, I actually wrote the similar paper several years ago. So sometimes I do more than 5 millimeters for the long lip patients. So the actually actually other surgeons are worried about the stability of the downward position of maxilla. Do you do the bone graft or the bone gap for the anterior parts?
Yes, generally, if it's more than a few millimeters of anterior disimpaction, I would do a bone graft, because the second most unstable movement in orthognathic surgery, based on Profit and White's original paper, the first is the transverse dimension, and the second is vertical. Not so much vertical impaction, that's very stable. Vertical disimpaction is the second most unstable move. So yes, a bone graft is necessary if you're going to disimpact that much.
Yeah. So what I'd like to emphasize, like the Padwa mentioned, actually the cleft the maxilla looks like a deficient in anterior sagittal plane and transverse plane, as well as the vertical plane. So some cases, actually, we should restore the mid-face vertical height. Not all patients, actually. If we lengthen the mid-face vertically too much, actually, the patient will have a very unusual vertical facial height. So I completely agree. And then in your experience, how much the maxillary advancement do you think would be possible?
Well, I showed one patient I was able to do 14 millimeters advancement. I know I'm very aggressive with my mobilization. And again, I'm not pulling on it as I'm trying to put the plate on or trying to put them in intermaxillary fixation with the splint. I have to really be able to mobilize it. And so for me, I don't really worry about 10 millimeters or 10 or 11 or 12 millimeters. You know, more than 10, 12 millimeters, I start to say to the family, I'm going to do this. The plan is to do it, just a Lefort 1. If I cannot mobilize enough, then intraoperatively, I will place the distraction device and will plan to finish it with distraction. I personally don't use distraction very often. Maybe once every couple of years, I have a patient in whom I'll do it. And I've found over the years that these are usually teenagers. They're very unhappy. They make their parents very unhappy, who then make me very unhappy. So I try to minimize everybody's unhappiness by, using the technique rarely. And if I do need to use it, I don't leave the device on for a consolidation period. I usually re-image and have a custom plate made, and then we'll take the device off and plate the maxilla. Bone graft is necessary so that they're not walking around for months with this external device on.
Yeah, I completely agree with your the answer. Actually, the clinical practice would be quite similar with yours. Actually, I usually apply the Lupert 1 distraction 1 or 2 times a year, like you. So, but mostly my maxilla distraction is only focused on Lupert 3 or Lupert 2. So I could understand why you answered like that. So, because there are many other the participants, so I will turn the chance to the guy.
Thank you.
Yeah.
Okay, thank you, Professor Choi, and thank you for your questions. And the next one, I would like to have the Professor Nobuhiro Sato. Yeah, Professor
Hi.
Sato, yeah, please give your
Hi,
comment.
can you
Thank
hear me?
you.
Okay, thank you. First of all, I am not professor, associate professor. It's nice to meet you, Dr. Bony Padwa. I'm Sato from Japan. I would like to begin by thanking you for your impressive presentation and also for sharing your experiences and insights. Today, your presentation focused on Cleft OGF experience from high volume center. That was a great overview. Basically, the strategy and the concept is same as our university. It is something I fully agree with your points. And I have few questions from your presentation. May I ask?
Sure, happy.
So, yeah. So I am plastic surgeon. So I am focused on aesthetics. The 3D simulation is a crucial tool for patient care, but I feel the gaps between simulation and real surgery. So especially in the simultaneous genioplasty. The most basic reason is the difference in the position of patient face, which means the difference between standing, sitting, and laying down on the bed. In addition, the face is swollen during the surgery. When we see the patient's face on the operative table, I always am confused about decisions regarding the movement range of chin. So do you have an experience where you recognize the need for genioplasty adjustment after OGS? What are your thoughts on this issue to prevent from falling into a big mistake?
So I think I understand your question to mean, how do I make a decision about genioplasty in advance, and do I change my mind on the table because they're swollen,
Yes.
and do I do afterwards?
Well, you are right.
I honestly, I haven't experienced, especially nowadays with virtual surgical planning. You are correct. The surgical, and we've had many papers on this. The proposed plan, the soft tissue proposed plan is not accurate. So you can do the genioplasty movements and show it to the patient and look at it yourself based on virtual surgical planning, but that 3D picture is not in any way accurate. And I mean, it's close, but it's not completely accurate. So I agree, you can't use that alone, but generally I rarely nowadays make a decision about genioplasty on the table because we're using our virtual surgical plan, because even though it's not exact, it's better than doing it in 2 dimensions with the dolphin planning. And so I haven't had an experience where I've been unhappy post-operatively with what I've done with the chin intraoperatively. And in the United States, the orthognathic surgery, including the genioplasty, we would be covered by insurance. But if we did the genioplasty secondarily as another operation, because it would be considered only cosmetic, it may not be covered by insurance. And then it's very expensive for families because at least at Boston Children's Hospital, we don't have a cosmetic anesthetic package. And so it would be really prohibitively expensive for most patients to do this as a second procedure. I hope I answered your question.
Yeah, I got it. Thank you very much. So one more question. Can I ask you?
Please.
Okay. Thank you. So regarding the relationship between LUF41 and speech, if the patient who needs to LUF41 had pharyngeal flap on their soft palate before osteotomy, how do you deal with that, the presence of pharyngeal flap? Cut the flap or preserve the flap? You change the advancement plan or redo pharyngeal flap?
Never cut it. The only reason we would ever take the flap down would be if it's a non-functioning flap. So if they have VPI and are going to need another flap, then there's no reason to keep it. So I will take it down at the time of Le Fort 1. I generally do not change my plan, even my plan for advancement, based on a flap. Again, I found that the way I'm very aggressive about my mobilization technique, and I've never found it to be a problem doing an adequate mobilization, even with the flap in place.
Okay. So I understand. So thank you very much.
I think when people come to watch me do a Le Fort 1 and they see what I do with that Smith spreader, and I'm sure other people have, it can't just be me that have figured this out, but I think people are very surprised at how aggressive this is. And I think people are in general uncomfortable doing that. And so they aren't able to get the kind of advancement that I'm able to do, because I'm just so much more, I think, aggressive than most people in terms of really getting the Le Fort segment to advance.
Okay. Oh, thank you. Give me your comment. Thank you very much.
Okay, thank you, Nobu. And next on, I would like to invite Professor Lunjo Low to give Professor Low's a comment. Thank you, Professor Low.
Hello, Dr. Padwa.
Hello.
Very nice to hear your talk, and I actually learned a lot from your presentation. I understand that you mostly do single jaw OGS for patients with Cleft. It's mainly Le Fort 1, and I saw your case, the cases in your presentation. There are so many difficult cases to me, because in Chang we do not really have so many difficult cases like severe discrepancy between the upper and lower jaw. But however, we do a lot of two-jaw OGS because in our Taiwanese patient, we do have a lot of mandibular asymmetries, especially for unilateral Cleft. It's so easy to find facial asymmetry, especially from the 3D simulation. I'd like to hear your comment or your technique, how you do such a big advancement of the Le Fort 1, because every time I did a plan, if my Le Fort 1 advancement is more than 7 millimeters, then I become nervous, because if I advance more, I know that the postoperative relapse could be more. So how you manage the Le Fort 1 segment during the operation to make it loose, less tension before the prey and screw fixation? I think that many listeners would like to learn from the technique.
So you know, John Mulliken is writing his book, and he really wanted me, so we have had a very close collaborative relationship for the past many decades. So he asked me to write this chapter for his book, and he wanted me to video what I do. And unfortunately, it's very difficult to get a video camera in to show, but I'm going to have to do it because so many people ask this question. It is, you know, I do a standard osteotomy and a standard down fracture. I then use row disimpaction forceps to just mobilize, make sure that I'm free from the pterygoid plates. We may pull a little bit with the row disimpaction forceps or even pterygoid lifts, but I don't spend very much time doing that. I used to, holding it for a long time. I found that pushing from the back allows for more advancement than pulling. And so that's why when I put that laminar or the Smith spreader in, I put it between the pterygoid plate and the posterior maxillary wall, and I open it up and you can see muscle fibers. Sometimes you can even see muscle fibers still attached. So that would be remnants of the pterygoid muscle still attached to some part of the posterior maxillary wall. I use an bovie to remove those from the posterior maxilla. Usually that is enough to get the advancement. What Dr. Sato, Professor Sato mentioned and asked about the pharyngeal flap. Sometimes the pharyngeal flap does limit, can limit my advancement a little bit. So I'm sorry I said that it didn't. Because I can feel that I'm nicely advanced, but it's tight in the midline. And then what I'll do is I will bluntly dissect along the plane to sort of separate the pterygoid, separate the pharyngeal flap from the nasal mucosa and get it all the way off so that especially medial to the greater palatine vessels is sometimes where it's very tight, and then in the midline. So those are the things I do, and I spend time doing it. It's not it's not something that I do in 2 or 3 minutes. Sometimes takes 10 or 15 minutes to do some gentle, slow stretching. But I would never, I'm very careful to make sure that literally I can use my finger or something, to grab onto the maxilla, maybe like a bone hook or something, and gently pull it forward to get it either into the custom plate or into the splint. Because if you're really trying to pull it forward to get it in place, you'll definitely have relapse. Most definitely have relapse. So I hope that explained it. It's I'm very aggressive. I guess that's all I would say. More so than most people, because when people come to watch me, they're like, wow. That's kind of frightening.
So do you routinely ligate the pedicle, the posterior descending pedicle?
I don't routinely ligate them. If they're really nice, robust, nice big vessels, usually they'll tolerate that kind of spreading. But if they're thin to begin with, I know they're going to avulse, and then I won't even bother to wait. I'll just clip them.
Okay.
And ligate them.
The other issue I would like to hear your comment is that you mentioned that for all the patients with cleft deformity, not only the skeletal dental, but also other associated at the same time. For example, you mentioned that septal deviation, nasal obstruction, residual oral nasal fissura, lip deformity, nasal deformity. How many of them you will deal with during the bone surgery?
So I would close a fistula. I would put a bone graft in. I don't do anything to the nose. I'm an oral and maxillofacial surgeon. I do not do cleft rhinoplasty. So I don't work very much on the nose. I don't try and straighten the septum. Plus the nose changes with the Lefort 1. So I don't really work very much there. I will correct the chin deformity, and I will correct the cleft lip, lower lip deformity at the same time, but no nasolabial revision at all. but all the other things.
Yeah, that's nice. So it is a kind of two stage. You will leave the soft tissue problem to the other surgeon.
Yes.
The other thing is that I heard that you do simultaneous bone graft to the alveolar cleft during the level 1 osteotomy. Is that correct?
Yeah. If they need it, yes.
Oh, okay. Because we did the same thing before, but we found that the bone loss rate or infection is quite high.
I would only do a bone graft. There are two times I would do a bone graft. One, if they've had a previous bone graft, but they need a little extra bone for implant placement, that I would do at the time of Lefort 1. And if they have a residual oronasal fistula and alveolar cleft, and I've decided to do this as not as a staged procedure, then I would close the fistula and put a bone graft in. But in general, I prefer staged surgery where I do the bone graft first and then the Lefort 1. For me, in my hands, I think that gives the best result.
Is that a cancerous bone graft or cortical bone graft?
Depends. So if it's to increase the thickness for implant placement, it's usually a corticocancellous graft, and I either take it from the septal crest if they have a nice thick septal crest, or I take it from around a wisdom tooth. If it's just a residual oronasal fistula and I want to add bone, I use cancellous bone. Sometimes I can take it from local areas. Sometimes I take it from the iliac crest at the same time. But that's not very typical.
Okay, so you can always repair the nasal floor very successfully without exposing the bone graft.
Yes.
Okay, very nice. Very nice to hear your talk, and thank you very much.
And then one last thing. When I say I don't do bimaxillary surgery very often, you are absolutely correct. There's asymmetry. And so in those patients, of course, you have to do bimaxillary surgery. I'm talking about bimaxillary surgery purely for the sagittal problem. And
Okay.
unlike your population, yes, you often have not just asymmetry, but your population has bigger mandibles.
Yeah.
In the Caucasian population, they're like me with small mandibles. And you don't want to have to move the mandible back when they already have a small chin. So that's why, our patient populations are a little bit different, but absolutely bimaxillary surgery if there's asymmetry. I was just mostly discussing the sagittal problem.
Thank you very much, Dr. Padwa.
Thank you.
Thank you.
Okay, thank you, Professor Low. Now it's going to the Q&A sections. I heard some of the question is quite similar.
Back to you, Dr. Cho.
Yeah, I got it. Yeah, okay. Let's back to the question section. So I have to condense some similar question from our participant. I know a lot of participants, just like our panelists, is very curious about your technique doing the level 1 osteotomy. They are curious about how do you perform the level 1 osteotomy using the Smith splitter, how to use it without damage to the mucosa and the tuberosity, because it's hard for you to take the video, right? So could you explain it in detail, or you allow all our participants to go see your operation in person? Yes.
In your incision, you're still in your incision and you come from the side to get to it. That makes sense. It's hard to describe.
Okay, thank you, Professor Padwa. And the next question is when you're doing the level 1 into the multiple pieces, how do you fix the premaxilla area? Yes, please.
So, obviously you have to be very careful, because if you're doing it in 3 pieces and there's a residual fistula on the palate, you have to maintain your labial pedicle, right? Because you can't cut through that. That's the primary blood supply coming to the premaxilla. On the other hand, if you don't have any residual fistula on the palate, then you can cut across the labial pedicle, okay, because the maxilla is got an intact blood supply coming from the palate. They're two different things, right? So if you have an intact palate and you're doing a 3-piece Lefort, you would do it just like any 3-piece Lefort. You'd use a plate across the premaxilla. If, on the other hand, you have a patient that has a residual fistula, you have to close the fistula as you bring the minor segments forward, as I showed in my one patient that I showed in the talk. Then you have to maintain that labial pedicle, and you have to be very careful. In those patients, I would use standard fixation for the 2 lateral segments, and I would use a splint, 6 weeks with a splint to hold the premaxilla in the correct position. I would not plate the premaxilla. Does that make sense?
Yes, got it. And the next one is what is your majority of the bone graft, the source for the bone graft in your orthodontic surgery? Yes.
So if we're using bone graft just for stability, you have a large advancement or you have a large disimpaction, I'll use cadaveric graft.
Okay.
If I'm trying to add bone for either placement of a dental implant or for a bone graft because there's missing alveolar bone because they never had or had a failed bone graft, then I would use iliac crest bone.
Got it. Okay, so the question from the Dr. Tinchen Lu is what is your technique for the bone graft over the maxilla after the 4-1 advancement? Do you have any special technique to stabilize the maxilla to prevent the further relapse?
Oh, you mean if I do a bone graft for stability purposes?
Yes.
Is that what we mean? Okay, so again, I use cadaveric bone. We sort of make it like a T so that there's some bone going into the defect, into the advancement defect, and bone along the anterior wall. And then I usually secure it with 1 or 2 screws.
Okay.
Does that make sense?
Yeah, bilaterally, right? Bilaterally.
Yes, bilaterally, and usually between the medial and distal foot, the foot plates on the medial and lateral buttresses. So it's usually about a centimeter, maybe less, in terms of anterior posterior dimension.
Okay. Next question from Dr. Urago. He is asking that do you use the BMP in bone graft at the time of the 4-1 osteotomy? BMP.
I'm not a big fan of BMP. So I use it in special cases. In the few cases in which I've had a non-union in a Lefort 1, I've used it there because it's been shown to be very effective for sinus lifts in preparation for implants. So in the sinus, I've used it in those circumstances. But no, generally, I wouldn't use BMP. I mean, occasionally I would, but not typically.
Okay, so
it's also very expensive.
Yeah. Okay, so the last question is when you perform the 4-1 osteotomy, how do you usually cut the tuberosity before down fracture? Yeah.
I use a standard osteotomy with a pterygoid osteotome, and I just put the osteotome between the pterygoid plate and the posterior maxillary wall. I don't cut the tuberosity.
Okay, great, got you.
Which gives me bone to push against with my Smith spreader. Okay, yeah. So I think that probably next time, or we have the opportunity to go visit the Professor Padwa's operation in person. Seriously, yeah, you cause us a lot of curiosity. Really want to see. Sorry. Yeah, I know. I wish I could. I have to figure out some way to video this. It's just not easy to get in there and somebody's mouth way in the back and to be able to see it. But all I can say is that I think I'm just very much more aggressive than most people. Sure. Yes. Yeah. Thank you very much. Okay. Yeah, I know. Somebody said use an endoscope camera for a video. I do know about that technique. we've used it for cleft palate repair, some of my colleagues. So I will try the endoscope to get a good video of this.
Great, thank you. I would like to ask in our panelists, the Professor Choi and the Professor Sato, do you have any extra questions to Professor Padwa? Yeah, Professor Choi. Yes.
Yeah, so one more thing I would like to ask is related to the lower lip deformity you mentioned. Actually, I studied the similar issues for several years. So for the solution of the anterior, rotated, the lower lip deformity, the mucosal excision is enough in all cases. So sometimes actually Abe flap would be the wedge resection is sometimes necessary in spite of the scar, but
Yeah.
well, the Abe flap would be more ideal in my hands. So what do you think about this?
Well, I learned from John Mulliken. He would never use an Abe flap ever. I think he hates that thing. And then he showed me what his technique. So I use his technique, which is a bilenticular excision. So yeah, it's narrower in the middle and wider on either side. And so in general, I found that to be very helpful. But no Abe flap. But I think he would. That would put him right over the edge.
Okay, thank you, Professor Choi. And Professor Sato, please.
Hi. Okay. So, Dr. Padwa, thank you very much today. I've learned many new information from you. So grateful and thankful for giving me this opportunity. Thank you very much.
Okay, thank you, Professor Sato. So finally, I have to pay my great gratitude to Professor Padwa to giving us so special lecture with the very several difficult cases. A lot of hypoplasia over the maxilla and over the mandible as well. So finally, I would like to invite all our participants to turn on and to show you a beautiful smile. We have a photo time, group photo in a very special time, and take the photo with our presenter, Professor Padwa, together, okay? I know it's a very late time in Asia, but I think it's early morning in United States. So show us your spirits and keep your smile, okay? And I will count to 3, and please give me your beautiful smile. Okay, 1, 2, cheese. Okay, may I have one more? Thank you very much. Okay, I will count to 3. Please show your smile. And probably you can give me your heart, or you can give me your triumph. Okay, 1, 2, cheese. Okay, thank you very much, everyone. And good morning and good evening. And thank you, Professor Padwa, for your beautiful lecture.
Thank you.
Thank you, Choi. Thank you, Sato.
Yeah.
Thank you, Professor Lo. Thank you, everyone.
Thank you.
Thank you. Have a nice
Thank
day.
you. Bye-bye.
Good night.
Thank you.
Bye.
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 Thank you. Thank you.